Hey everyone, we are just letting everyone come in, so I think we'll give people just another minute to join before we get started. All right, we're seeing some familiar faces. I love it. We'll give people just one more minute to join, and then we'll get started. Hello. All right, I think we'll get started. So I'll go ahead and share my screen. All right. Can everyone hear me okay? See me okay? It's nice to see everyone again. This is our third session of the CBCT Collective, so it's great to see some familiar faces. We will go ahead and get started now. So today's session is Read It Like a Radiologist. It's going to be a radiologist that's a tongue twister, top tips and tricks. So we're going to go ahead and go through just a little bit about how I review a scan and how you can kind of start forming those positive patterns in terms of reviewing CBCT scans. So a little bit about me. I feel like you guys have gotten this before if you've joined us for sessions 1 and 2, but I went to UOP undergrad and then University of Washington for my residency, and I am now a radiologist at Beam Readers. So here is our dog meme for the day. I thought this was really cute. I hope none of us ever make our patients feel like this. All right, so my disclosures, only one is I am a radiologist at Beam Readers, and housekeeping, same as it's been before. So feel free to take notes via screenshot throughout the session. I feel like today this is especially important because we do have a lot of great visuals of anatomy and going through a CBCT scan. The meeting is going to be recorded though, so if you don't want to take notes and you want to be present, you'll be able to have all of that information afterwards. And we will have an opportunity for Q&A after I go through kind of the more informational part of the session. But like it's been before, if you have anything burning all the way through, I really want this to be a discussion, and especially today, it's going to be, about how you guys are going through a scan. So the whole goal here is to empower you and give you, all the skills that you have. So feel free to ask questions throughout the session. We do also have Dr. Martina Perrone on here, and she's going to be helping me monitor the chat. She's our VP of Radiology at Beam Readers, so she is an incredible resource to have here today. All right, where we've been. So our last session was session 2. We really talked about scan quality, the factors that influence that, how to prepare a patient for scanning, and then a little bit about the basic software tools and the DTX software introduction. So I just wanted to check in before we get started. How has that been going? I know we kind of had a little bit of homework after last time to start practicing how to go through the software. Did anybody have any follow-up questions or anything before we dive into our next topic about the DTX software? Can I get like a thumbs up if anybody's been practicing a little bit with that. And I apologize, I don't have my second screen today. So Martina, if anybody does have anything, if you want to just hop in and let me know.
Yeah. Just so everyone knows, at the top of your screen, there's a little smiley face that says react, and you can just give Samantha thumbs up or loves or claps or laughs or surprises that way. So you don't have to type, but I do have somebody typing. We'll just wait a moment till it came up. Oh, somebody said the orientation of the patient has been really helpful. Thank you. So that's great.
Awesome. I love
Yeah,
to
that's
hear
one
it.
of
And yeah,
those secret radiologist tricks, right?
and it's kind of like once you do it, it becomes addictive and you can never look at a scan without doing that again. So I'm glad that was helpful. And we can go through any of those things. If there's anything that would kind of help tie everything together, that's what this session is for. So we can do that at the end of today as well. So we'll try to get through all the information relatively quick today so we have enough time for questions at the end. All right, so today's agenda, we're going to work on creating a systematic framework for reviewing CBCT volumes. We're going to review some of the basic anatomy that's commonly evaluated in CBCT scans. I really want to be clear that today is not going to be an all-encompassing anatomy overview about CBCT. That would just take like so much more time than an hour and a half to be able to learn all of the 3D anatomy that, we take 2 to 3 years to learn in residency. But my goal today is really to empower you to know what is out there to know and to give you some resources on if you're interested in learning beyond the landmark foundation that we set today to be able to let you have those resources to do that. We'll also be discussing how to evaluate when to refer to an OMR and learning how to integrate CBCT into your clinical workflow. All right, so systematic review. This is Martina's little image, so thank you for this, Martina. But the main thing that I want to start on is the most important aspect when it comes to reviewing a CBCT scan for us radiologists and for you as the dentist, if you're choosing to review the scan on your own, is to have a system and use it every time. So the way that we make sure that we don't miss anything is by going step by step through a CBCT scan. And we've actually already started learning this. So in the past couple sessions, we talked about the technical analysis of the scan, how to tell if the CBCT is of diagnostic quality. Are we seeing any motion artifacts, anything like that? Last time we talked about orienting the scan and evaluating for asymmetries, how to adjust the brightness and contrast of a scan. And we started to learn about, the things that you can do from there. So making a reconstructed panoramic, making the reconstructed views of the TMJs. And today we're really going to dive into the rest of the stuff. So evaluating all of the structures in a scan and how we do that. So it's kind of funny when we talk about this because I will say that every radiologist does this stuff differently. And it's okay if every dentist has a little bit of a different way that you do it as well. But the most important thing is that you find what works for you and you're consistent with it. So all of these this list and the extraoral structures right here is a list of all of the things that we're looking at as we're evaluating a scan. Obviously, some scans don't have all of the anatomy if the field of view is the smaller, but all of the possible things that you can see in a scan. And you want to come up with your order of how you are going to look at every single one of these every time. And like we've talked about, we have those 3 views, the multiplanar reconstruction that we have, kind of discussed how we're visualizing in the CBCT. And we have our sagittal view, our coronal view, and our axial view. And there's different anatomic features that are better to look at in each view. So we have a little bit of detail here. I'm just going to make this a little bit bigger for us. In the sagittal view, a lot of times we're looking at our dentoalveolar structures, and the coronal view, it's really good for looking at the anterior teeth, the periapical area of that. And then in the axial view, it's really good at looking at the incisive canal. If there's any resorption or caries, it tends to have be a really good view for looking at those things. So the most important thing here is not that you go in this exact order to look at these structures, but it's that you figure out a method by which you are going to be able to hit all of these structures in your review. All right, so let's walk it back a little bit and just talk about general ground rules for describing an image. So every time we discuss a radiograph, and this is whether it's a 2D radiograph that you're just talking about, in your notes, or a 3D radiograph, CBCT, that you are, discussing. And every single one of our reports, we're going to be describing what the image is before we talk about anything within the image. So we're going to describe the slice. If we're just looking at a still image of the CBCT, is it the axial slice, the coronal slice, or the sagittal slice? We're going to talk about the type of imaging modality. So is it CBCT or is it, MDCT? You guys really won't be dealing with MDCT or MRI, but it's still important to say what type of image it is, whether it's a CBCT or a panoramic radiograph or an intraoral bite wing or PA. And then the level or location of the slice. So for example, we'll just practice with this one. This is an axial slice. It's a CBCT that we're looking at, and we're at the approximate level of the mandibular condyles. So by me saying that, I'm just giving us all a general idea of, a playing field of knowing what we're talking about around the image before we dive into the contents of the image. All right, next up in terms of ground rules, we're going to want to always hold an image of what is normal in our heads. This sounds really easy, but it's actually, I think, one of the hardest parts of radiology. So, we can think that we know what normal is until we see something and it just is a little bit not right. So we're going to want to always kind of have a really consistent understanding of what is a normal structure so that we can compare that image on our heads to what we're seeing in the scans that we're evaluating. So here's an example of, on the left, more of what we have, a normal image of two primary teeth looking like. And then on the right, we can have where we can appreciate what is called gemination of both of these teeth. So we see this, maybe we know what it is, maybe we don't know exactly what it is, but if you're able to evaluate, that looks a little bit abnormal, that's when we can go back and use our other tools to figure out what's wrong with it. So a tool that I always like to use is to compare the image that you're looking at to another scan if you're not quite sure. For example, if a bone contour of somewhere, or like the angulation of a tooth or something, isn't really seeming normal, you can pull up another scan and compare it. Is it the same? Is it different? Obviously, every person's anatomy is going to be a little bit different, but it gives you a good, ground truth to start with. And when in doubt, refer to an OMR. So we get cases all the time from dentists and specialists that are just like, hey, I noticed this thing. Can you tell me if it's normal or abnormal? And that's a great way to get another set of eyes on something. And also for your learning, for you to be able to, build up your confidence in terms of what is normal and what is not. All right, so here we've got an example, and I'm not going to ask for a little participation on this one. It's our first time diving into that, but I'm going to ask for some participation. Does anybody notice anything abnormal about these images? It can be anything. We'll give people a second to think about it. Feel free to just hop in if you want to chime in as well. Anybody? Remember, there's no wrong answers. We're all learning. Okay.
How about we just do people think it's normal or abnormal?
Thumbs up, thumbs down. I'll take that.
So superior to the maxillary sinus, there's some lesion or tissue.
Great. Love that. Okay, that was a great place to start. I'm going to give us another little bit of hint, and maybe this will make us feel more confident. All right. So now we're comparing two scans. We've got the top row is one scan. The bottom row is another scan. Let's say you were seeing this top image in your scan and you were like, something seems a little funky. Let me pull up something to compare it to. Can anybody tell me any difference now that they're visualizing between the top row and the bottom row? Maybe. Okay, I can
A
go for
nasal
it.
blockage.
Nasal blockage. All right, so something going on with the nasal cavity. Yes.
I've got someone saying something with the nasal cavity and the septum.
Yep, absolutely. So that's a great place to start. So we can see that our nasal septum is interrupted here. Down here, we can see that it's continuous, a little deviated, but it's continuous. And we're also seeing our middle nasal turbinates right here are totally missing on the right side. And there's a discontinuation in the border between the right maxillary sinus and the right side of the nasal cavity. Um, we can also appreciate in our sagittal view, we've got an extension into this typical bony area here, and where we have our brain happening up here in the soft tissue region. So whereas in the lower image, we can appreciate the continuity of the sella turcica. So we definitely have a lesion happening here. I think it's pretty helpful to be able to compare it to the more normal scan and actually see where our bony borders are missing. All right, so moving on in our systematic review, I'm going to talk about the part that I think most people don't like, and that's that we encourage looking at the region of interest last. So if you, whatever reason that you're taking the scan for, if it's for a certain tooth or clinical signs that the patient is having, I'm going to encourage everyone to go through your systematic review like normal. So whatever list that you come up with of the way that you're going to go through anatomic features, wait to look specifically at that region of interest till the end. And the thing that this is going to do is it's going to reduce inattentional blindness. Sometimes we're so caught up in like going to the good stuff, going to the cake, you might say, the dessert, that you skip all the meat and the potatoes, where there might be other findings. And sometimes we have findings that are totally asymptomatic in scans. You will find that if you're taking CBCT scans regularly. So it's really important that we're able to go through the rest of our scans systematically, and then we can zone in on the good stuff, the dessert, at the end, and be able to pinpoint what is exactly is going on for that patient. And another thing is I want to encourage you to consider also looking at the teeth last. I know this is also hard because it's like, we're dentists. We want to go straight for the teeth. That's what we know. That's what we love. But with CBCTs, there is so much more anatomy that we can see versus looking at our 2D intraoral radiographs, even compared to panoramics, where there's all this overlapping anatomy. So I'm going to encourage you to go through all of the rest of the anatomy first, and then focus in on the teeth, and then focus in on our region of interest. So here's an example that I love. I'm going to ask for some participation in this one. What do you see here? Do you see anything interesting in this image? This is obviously not a dental image, by the way. This is a medical CT. I'm going to wait on this one until someone gives me some participation. So
we've got somebody typing.
Okay.
There's a gorilla. Somebody's got a keen eye.
There's a gorilla. Awesome. So this was actually a study done with radiologists, and the radiologists were given this image and were asked to look for, I think, nodules. And so they were, busy looking for that. And somewhere around 80% of them, or I think that's not an exact figure, but a really high percentage of them actually missed the gorilla in the upper right hand portion of the image, even though the gorilla was something like 40 times bigger than the average nodule that they were looking for. And it's because of this phenomenon called inattentional blindness, where we just zone in and we're looking for the thing that we expect to be there in the image. So this is a really silly, goofy example, but it is kind of a crazy one, just to be on the lookout for everything else that we're going to talk about that you might be seeing in these CBCT images besides that one thing in the area of interest that you're looking for. All right. One more area that we like to consider and just be aware of is satisfaction of search error. So the satisfaction, that's another tongue twister. Satisfaction of search error is when subsequent abnormalities are not identified after we find one thing. So this would be, for example, a patient comes in, they're having pain on a tooth, you identify some findings that you think might have a vertical root fracture. And so you take a CBCT, you see a vertical root fracture on the tooth, and you're like, yes, I got it, nailed it. However, there might be another lesion on the other side of the mouth that you also captured in that image that you didn't quite catch because you thought you found the thing causing the pain. And so the way that we address satisfaction of search is to systematically review the scan for each entity visualized, even after findings are noted. So it can be so, it can be so, oh my gosh, what is the word that I'm thinking of?
Tempting.
It can be so tempting to want to go, thank you, Martina, and describe in depth that one thing that we find, the first thing that we find, and be like, yes, I solved the problem, because that's what we're doing. We want to solve problems. We want to get people out of pain. But I'm going to caution you guys on that one, because like we always like to say in radiology, a patient can have as many diseases as they please. So a patient can have multiple things going on. I've seen a million incidental findings in a case that didn't even relate to the reason that the person took the scan. So, proceed with caution, use your systematic review that you're going to come up with to go through the structures one at a time to make sure that you don't miss anything, because that is the goal. All right, anatomy review. So now we're going to go into, like I said, we are not going to be able to review every single piece of anatomy. That would take way too long. And there are courses for that. So I really encourage, if you are into CBCT, you've bought into it, you've decided, yes, I'm going to utilize this skill set to, improve my patient care, I encourage every single one of you to take an in-depth anatomy review course, because there is so much anatomy in the maxillofacial complex that we're not used to, looking at when we take our 2D images. But the thing that I'm going to emphasize today is that cross-sectional anatomy is the most important part of looking at CBCT. So learning how to look at these scans in the three planes of view, the sagittal, coronal, and axial. It's really different than just thinking about the skull in terms of, the bones like we might have learned in dental school. We really need to get used to looking at things in these three different slices. A really, really helpful tool beyond doing a dedicated course can be just Google and YouTube. So you can just search up, secret hint, I do this all the time to this day. When I see something that's abnormal, I'm like, let me just Google that really quick. Let me just find some more examples of this thing that I can compare this scan to. So you can Google, cross-sectional anatomy, CT bone window, or skull-based anatomy radiology. I didn't put it in here, but I'll put it in the chat later. Another tool that I like to use, I actually pay for it. It is a paid thing, is Imaos online. We used it in residency, and it's medical CTs, but you can actually, it's a great tool to just learn the anatomy of the maxillofacial region. And it allows you to scroll through in the different planes with labels pointing to the different areas of anatomy. So I'll put a little text box in at the end if you want to, look into that. But also there's so many great resources, videos where you can learn a little bit more anatomy and just kind of check yourself. Am I looking at the thing that I think I'm looking at? Oops, that should have been earlier. That's okay. Okay, here we go. So anatomy review. For each structure that we look at, each of those structures that we looked at earlier that we want to systematically review, we want to be evaluating the shape and size, the symmetry, cortices and outlines. For entities that are made up of bone, we want to be looking at the trabecular pattern, so like the makeup of the bone. And a good tip that I like to use is to compare that area to surrounding areas. So if you think an area looks like it's lower density or increased density, compare it to the surrounding areas or the other side, because every person is a little bit different too. So if you see everything looking a certain way, that might just be a normal for the patient. So try to compare it to, some of the other areas of bone. For air spaces, we're looking for, are they well aerated? And then are they patent? We're going to talk about this a little bit more later, but certain areas, it's important that we want to make sure that areas that are supposed to provide a passageway are patent. And then for soft tissue areas, we're looking at the contours of them, and we're looking at any density changes or abnormalities or anything of higher or lower density within the tissue. All right, so when to utilize all three planes. When we come up with our systematic review of a way of looking through all of these structures, a lot of the structures we're only going to visualize, in depth looking at it in a certain plane. And that's because there's certain planes that are better to utilize for each piece of anatomy. However, there's kind of 3 rules of thumb for times that we want to make sure to look at a structure in all 3 planes. And the 3 rules there are A, if something looks weird. So if you notice something, you go, whoa, that's not normal. Like that, the scan that we were looking at before that had kind of the missing border of the right maxillary sinus. Whoa, that looks weird. I'm going to drag my crosshairs over. I'm going to look at that in all 3 planes. If you see something and you don't know what it is, so if you see a calcification, you're like, whoa, that's not normally there, drag your crosshairs over, look at it in all 3 planes. And then your area of interest. So the area of interest, you always want to go into depth at the end and look at it in all 3 planes. And I can show us a little bit on how we'll do that later today. But you want to make sure that you capture some good images of that and really know what's going on there. So volume rendering, I think we talked about this last time, but I want to kind of touch on it again. This is going to be for a general overview of what's going on, not fine anatomic detail. So the left and right images are, believe it or not, the exact same scan, just with different thresholds of the bone to include or not include in the image. So it's really, you can look at that left image and go, whoa, that looks really, really scary. But if you change the threshold settings of your software, it can look like on the right. So it's just important to note, number 1, that those settings exist to play around with that. And number 2, we're using the volume rendering as a general overview, not to diagnose anything specifically. But it can be something where you can look at it, go, that looks a little bit asymmetrical, or that looks not normal. And then you dive into it in your 3 planes of CBCT. Okay, now we're going to dive into describing radiographic features. So with a specific feature, so a specific area that looks abnormal or an area that you've identified there's a lesion there, we want to evaluate these things: the location, the shape and the size of that entity, the margins of the entity. So if it's a periapical lesion, is it corticated or is it not corticated? Is it disrupting anything? The internal density of the entity, is it increased density, which we call in radiology hyperdense, or is it decreased density or dark, which in radiology we call hypodense? What is the internal structure of the density like? Because sometimes an area isn't actually one density. It might be overall kind of a darker thing, but there might be an increased entities within that are brighter. And then what are the effects on the surrounding tissue or structures of that entity? So dentoalveolar, now we're just going to run through very generalized the different areas that we are going to evaluate when talking about CBCT. So like I said, we're not going to hit all of them, but I'm going to give a general overview of the most common ones that we're looking at and kind of some of the features that we want to be evaluating. So for looking at the teeth, I find that using the sagittal, the corrected sagittal, or the cross-sectional view for the majority of the analysis is the easiest. And I'll go into kind of what each of those views are. This right-hand image that we're looking at is the sagittal view. So it's really good for looking at posterior periapical areas of the teeth. And then for the anterior teeth, usually adjuncting that with looking at the coronal view. So going forward to back is very helpful. And then I like to use the axial view, which is how we can, scroll up and down through the head to be able to look at any type of resorption, fine details with the pulp. chambers. So we can see on the right image, there's definitely some PDL space widening there and some furcation bone loss happening with number 2. Moving on to the paranasal sinuses. So a little bit of anatomy review. Our paranasal sinuses include our frontal sinus, the ethmoid air cells, the maxillary sinus, which is the one that we love to talk about in dentistry, and the sphenoid sinus. So you want to be evaluating all of these areas and their points of connection and drainage. So the things that we want to evaluate are drainage, borders, and contents when it comes to the paranasal sinuses. So maxillary sinuses, our maxillary sinuses, we have 2, the right and left, and they drain through a small opening called the maxillary ostium, which connects to the middle meatus of the nasal cavity. So we know that the maxillary sinus connects to the nasal cavity via the infundibulum and hiatus semilunaris, and we can't fully see that. So the way that we evaluate the health of the area is we evaluate the patency of the osteomeatal units. So we have an area right here showing a patent but narrowed osteomeatal unit on the right side. And here's a little diagram of more about the anatomy in that area. The sphenoid sinus drainage happens through the sphenoethmoidal recess. So we have a nice diagram of that. The top image on the left is really great. And maxillary sinus, some of the things that we want to evaluate when it comes to the maxillary sinus are the health of the sinuses. So we're looking for acute versus chronic sinus disease process. We're looking for soft tissue masses originating from or pushing into the sinus. And we're looking for conditions that grow into the sinus or replace the sinus space with either soft or hard tissues. So this is an axial view of pretty healthy looking maxillary sinuses. Ethmoid air cells and sphenoid sinus borders. So one of the most common anomalies that we see within the ethmoid air cells is a Haller cell. So that's when we've got an ethmoid air cell that is located inferior to the floor of the orbit right there. So that's an anatomic variation that we want to make sure to mention. And back to maxillary sinus, we just have a couple examples of descriptors now. So if I was describing the image on the right side, I would say it's a CBCT in the coronal view at the level of the maxillary sinuses bilaterally, and there's mild mucosal thickening along the floors of the maxillary sinuses bilaterally. So that's the soft tissue mass that we see here, and this is very common. We very commonly see it asymptomatically in patients. There is another common sinus finding. This is going to be a mucus retention pseudocyst. So we can see it's a little bit different than the previous images of the mucosal thickening. It's a dome shape, so we can usually really appreciate that in the coronal view and the sagittal view, how this is a semicircular or dome shaped. It's non-epithelialized, so there's no border, corrugated border here, and it's just it's an accumulation of soft tissue density. So it's very common, and it's also commonly incidental. So that's a pretty common one that we see people visualize in a panorama and want to take a CBCT for, but unless it's really large, there's usually nothing to do about it. And then we have true sinus disease. So versus the previous mild mucosal thickening and mucus retention pseudocyst, we can see something really funky happening here in the left maxillary sinus. We're seeing soft tissue entity opacifying most of the left maxillary sinus and extending into the left side of the nasal cavity. So the border between the left maxillary sinus and the left side of the nasal cavity is destroyed, and we see a soft tissue entity opacifying the osteomeatal unit there as well. So things that we're looking for in terms of true sinus disease versus those more inconsequential things that we mentioned earlier are the entity does not respect the boundaries of the maxillary sinus. There is border expansion and erosion, and there is disruption of the border discontinuity. So this entity ended up being an inverted sinonasal papilloma. Does anybody have any questions so far about the differences between those entities or how to differentiate between them? If you do, go ahead, shout it out. I want this to be able to be conversational if anybody has any questions instead of just breezing by. All right, we'll keep going, but go ahead and feel free to interrupt me if there's anything. So moving on to the nasal cavity, we have our nasal septum here, and then we have our nasal meatuses and concha, so the air spaces and the bony spaces of the turbinates. And then we have our ethmoid air cells more superiorly on either side of these. So when we're evaluating an image, we're going to want to evaluate the turbinates, evaluate the nasal passages or the airway spaces. We're going to want to evaluate the posterior nasal aperture and the anterior nasal valve. So if you see the anterior nasal valves being deflated or like there might not be able to be air passed through there, those are all things that are worth noting. And moving on to our airway. So we have three different regions of the airway, main regions of the airway. So we have the nasopharynx, which is the area behind the nasal cavity. We have the oropharynx, which is the area behind the mouth and the tongue region. And then we have the hypopharynx, which is the airspace of the throat. And so we're going to want to evaluate soft tissue contours. And the axial view, it's really, really important with the airway to evaluate for any asymmetries, because even the smallest of asymmetries in the airway can be consequential. So that's something that if you saw something a little bit asymmetrical, you might want to consider referring to a radiologist. We want to evaluate the palatine tonsils and the adenoids. We want to look at the pharyngeal recesses and the fossa of Rosenmuller. That's going to be the more superior anatomy. That's the area that if you see something that's asymmetrical, you're going to want to look into that a little bit further. And all of these things, I know that it can be kind of a jump scare with like the big names and the anatomy, but feel free to just jot down any of these that sound unfamiliar and Google them later. And I'll pop some resources on at the end, but it can be pretty easy to, review your anatomy as you're going, as we're seeing these unfamiliar names. So just kind of jot them down, keep them in mind if they sound unfamiliar, but don't be scared away. And then our airway measurements. So with our CBCT, we're able to take our airway volume and then our airway area. Usually the most important thing that we're looking at there is the airway, the cross-sectional area of the airway at the smallest portion of the airway. So everybody is a little bit of a different threshold. You can look at the literature for the specific threshold numbers that we're looking for, but you want to be looking at kind of the smallest area of the airway for that. And then temporomandibular joints. So when we're looking at the TMJs, we talked about this a little bit last time. We were able to set up kind of our TMJ splices in the DTX software, but we're going to be looking at two different areas when it comes to evaluation, and that's going to be the osseous components and the spatial relationships. So when it comes to osseous components, we are looking at the mandibular condyle. So the condyle itself, its border, is there any erosions, the osseous quality of the trabecular. And then we're going to be looking at the articular eminence and the glenoid fossa. So when we're looking at the osseous components of the fossa and the eminence, is there any flattening of the eminence? Is the fossa smooth? And then after we've looked at our osseous components, we're going to want to look at the spatial relationships of the condyle within the fossa. So is the condyle centered within the fossa? Is the condyle located anterior to the fossa? Is there any narrowing of the space there? And then we also want to remember that ideally we're having the patient in centric relation, or at least maximum intercuspation, to be able to evaluate the spatial relationships. You can't really evaluate the spatial relationships if they're biting on a bite block or something like that. And then cervical spine. So here's an example of what we often see when it comes to cervical spine. Sometimes you're just seeing a little bit. So typically we're seeing C1 to C5. It's often less or just like part of the cervical spine. We're looking at the vertebral body, the transverse processes, and the vertebral and facet joint spaces. And here's an example. This is an MDCT, but I know somebody wanted an example of some cervical spine pathology. And so here's an example where we're seeing kind of continuous flowing of the osseous portion of the anterior part of the vertebral body. So back here, we're seeing, intact cortices. This is an great example because you can't see the whole spine, but the contours appear normal. And here we're, seeing continuity of the cervical spine. Some other things that you might see, it's pretty common to see a little bit of sclerosis up at the dens process, just a little bit more dense than the rest of the surrounding spine. That's pretty normal. The real things that you're going to want to look out for are osteophytes. So any type of bony, spurs coming off of the vertebral bodies or the transverse processes, and then any type of hypodensities. So, dark spaces within the vertebral bodies like this, or a lack of joint space. So the entities being closer together than you would expect. And soft tissues. So this might sound a little contradictory to what we talked about last time, because you might say, Samantha, wait, I thought you said we can't see soft tissues in CBCT. Well, what we're mostly looking for is there stuff within the soft tissues? So all of this list is stuff that you might see within the soft tissues in different areas of the CBCT. So tonsilloliths, sialoliths, antroliths, which are calcifications to the maxillary sinus. We can see carotid artery calcifications. That's what we have an example of on the left, is cervical carotid artery calcifications. I know somebody else wanted to see an example of those. So these tend to happen around, they're a little bit posterior and lateral to the airway. So we got our airway right here. This is the axial view. So this is the approximate typical area. Sometimes they look like rings, but sometimes they're not really, fully continuous rings. So they can be a little spotty like this. And they usually happen around the area of C3 or C4. So if you have the vertebrae, the cervical spine imaged in that scan, you can use that to kind of tell where you're at and localize these calcifications. So that's an example of those. We can also see internal carotid artery calcifications. So that would be, within the paracellar region, or, within the head. And then we can see pineal gland and choroid plexus calcifications. Those are more age-related calcifications. We can see calcified lymph nodes. We see calcified thyroid and trapezial cartilage, ossified stylohyoid ligaments, osteoma cutis, and then foreign body calcifications. So, for example, dermal filler or chin augmentation, things like that. We can see those within the soft tissue as well. All of this to say, you might not know what every single one of these things is, and that is okay. The most important thing is that you're looking for it. And if you see something and you don't know what it is, you need to send that to a radiologist to be read to evaluate if it's real or not, if it's important or not. And if if any of these things scare you and you're like, I want to learn a little bit more about those, you can. If they scare you so much that you want to send your scans to be reported on, then you can do that. So that leads into when and how to work with an OMR. And I'm going to try to go through this part not too slow so that we have time to go back to our DTX software and we have time for questions today, because I feel like today is going to be a good time for questions. So to refer or not to refer, that is the question. So evaluate where you're at. This is kind of the 4 general areas that people tend to be in when it comes to sending their CBCTs. So we have some dentists who send every single scan to a radiologist to be read. We have some dentists who say they send their scan when they see something weird. We have some dentists who take CBCTs, but they never send them to be read by a radiologist. And then we have some people who don't take CBCTs yet. And I feel like in this group, we're probably on the earlier side of taking CBCTs and not yet referring or just starting to take CBCTs. So we'll kind of go into how radiologists can be helpful to you, because that's what this is all about, is empowering you guys and making sure that you are able to utilize your CBCT machines to the best of your abilities. So for those of us who don't yet take CBCTs, I feel like we mostly covered this in our previous discussions, but here is again the list of areas where CBCT will probably have a high diagnostic yield, and then the areas that CBCT isn't recognized generally for. Again, this is totally up to you. So if you feel that taking the CBCT is going to increase your knowledge and possibly change your treatment plan related to that case, go for it. This is just kind of a general outline. All right. So for everybody else who is taking CBCTs, we're going to talk about the different camps in terms of risk tolerance first. So if you send every single scan to a radiologist, you are assuming the lowest risk tolerance. You might be someone who's like, after seeing all this anatomy, everything that's going on, everything that could be within a scan, I don't want the liability when it comes to missing something. You might want to send every single scan to a radiologist, and that's totally okay. For those who send when they see something weird, you're assuming a moderate risk tolerance because you are on the lookout for things. You are able to gain more information if you see something that is weird. The caveat that comes to this is I find that it's generally not the things that we see that we need to be scared of. It's generally the things that we don't see. So this is why I recommend if you have just gone to CBCT and you're just figuring it out, try and send all of your scans, your initial scans, to be reported on. I think we mentioned this last time, and just see what happens. Go ahead and practice writing a report, practice going through the scan yourself, then compare it to the radiologist report and see if they're catching anything that you're not. And if you're kind of getting everything, then thumbs up. You're probably at a great place. But if they're catching stuff that you're not, it might just be a sign that you need to do a little bit more education before, assuming that risk. And then if you take CBCTs and never refer to a radiologist, you're obviously taking on the highest risk tolerance because you're not, getting that second set of eyes, that additional education that somebody who's done a residency has. So evaluating where you're at, training level as well. So if you send every single scan to an OMR, it requires less training on your part. So less CE courses, less education. Obviously, it's the highest cost because you or your patient is paying for a report to be written every time. If you're sending when you see something weird, that requires a moderately high level of training because you've got to be able to look through, the CBCT scan and be able to have the threshold level to know when something's not normal. That can be a really good allocation of resources if you're willing to do that level of training. And then if you take CBCTs and never refer, obviously it requires the highest amount of training. It's the lowest cost to you and your patient, except for CE courses to get the training, of course. Yeah. So to refer, not defer in general, I like to look at this for you to utilize oral radiologists just as you would any other dental specialist. So obviously we know general dentists who are jack of all trades, have done, a lot of educations. I know general dentists who can do a slam dunk root canal and feel really confident about that. And I also know endodontists who I'm have seen some questionable things. So all of that to say, credentials are not everything. It's not, this is not all about, do you have the certification of going and doing a radiology residency? One of the things that is important is, do you enjoy reading CBCTs? Just like some people don't enjoy doing root canals or do enjoy doing root canals, it's really just about the amount of time that you're going to spend doing this thing and recognizing that reading a CBCT is something that comes with taking the scan. So how valuable is your time to you? How long does it take you to review a scan, first of all? And could you be doing something more productive or lucrative or enjoyable instead? So if you've decided like, I don't think that sitting in a dark room and going through these x-rays is for me, that's okay, because there's a lot of us who are radiologists who have decided, yep, that is for me. And I absolutely love doing that. So if you don't like it, it's not something that you do have to do. That's why, working with an OMR is a positive option because we can be that person for you. We can be your teammate that's going to do that thing and let you get your time back to doing what you love. So I would encourage you to, use us just as you would any other dental specialist. If you don't want to review the CBCT or you don't feel like you have a skill set for that particular case, go ahead, punt it to us and we can be your teammate in that regard. So OMR skill set, what we bring to the table, it's going to be radiology reports, and that's going to include all of these things. So it's going to include an objective observation of findings, an evaluation of your area of concern, our best diagnosis or what the diagnosis could be in terms of that area, identification of incidental findings, and assessment of all periodontal structures. So airway, sinuses, TMJ, skull base, everything. It can also be a really, really great tool for you to be able to take that radiology report and show it to your patient, show them, the airway assessment, the assessment of their TMJs, and be able to talk to them about it. You end up, I think, a lot of times being a little bit like a superhero for them to be like, oh my gosh, I didn't know, that you could do all of this stuff within dentistry. So it can be kind of a great point for you to be able to show off a little bit and use any of those findings from the OMR. I also think that it elevates your credibility in the medical arena. If you need to refer, if you're talking with your patient about obstructive sleep apnea and you have a CBCT, you have, the data on that and the measurements. Any kind of systematic pathology, leukemia, brain tumors, Gardner syndrome, stuff that we see in the jaws, not infrequently, you're able to come in with, hey, this is what an expert said regarding this, and have your patient be able to bring that report to their medical doctor is pretty impressive a lot of the time. It also increases patient confidence because they are used to receiving radiology reports in the medical field. That is the standard of care in medicine, is that every radiograph receives a report in some capacity. You can also increase your treatment acceptance by having your findings validated by an unbiased third party. So as a radiologist, I am looking at the scan. I am not, I have no skin in the game when it comes to overdiagnosing a patient or, finding things that aren't there. It is, and you can, describe it to your patient as an unbiased third party who's going to help me provide the best care to you. A little note on incidental findings. This was Martina's math. So thank you for this math, Martina. But I thought it was a really, really nice point. So one missed periapical radiolucency, for example, can be $4,000 for a root canal and crown or extraction and implant. At just one incidental finding per 46 scans, the radiology reports actually pay for themselves. It can also help you actually find more treatment to perform if you're able to catch incidental findings in the scans. And on the other, end of things, one over or misdiagnosed malignancy or even a PARL, it costs you your peace of mind and it costs you your patient's peace of mind. So this is a way that you're able to ensure your peace of mind and not have to, have that floating in your head. Did I miss something? Did I not miss something? It saves you the time to take a scan, read and write the report, and it distributes a large portion of the associated liability away from you. So we talked about the medical legal implications of this in another session, but you're able to offload a lot of that to somebody else because you're no longer the biggest specialist looking at that image. So how to work with an OMR. I really like to share this with dentists. I feel like for even more my sake than your sake. But if you are sending a scan for a report, make sure that you provide your radiologist with your clinical findings and history. We get so many scans from providers who just say nothing. Sorry, my dog is barking in the background. Sorry about that. Let me know if you can't hear me. Okay. But we get so many providers who don't provide any clinical findings and history. So at a bare minimum, if you can let us know the vitality testing, pain, percussion, palpation, correlation with clinical findings is something that we say a lot. And we say that because we only have the information that you give us when you give us the intake for that scan. So the more clinical information you give us, the less likely you are to see that statement from us because we'll be able to, correlate it with the information that you provided. Another part is if you aren't sure what clinical information is helpful, more is always better. Also, contact us. So within Beam Readers, if you want to submit a report to us, and I can go over that a little bit at the end, there is a feature called Rad Chats, and you're able to message your radiologist directly and ask questions. So you can always shoot a message before or after the report saying, hey, I don't really understand this, or hey, I have this thing. I don't know if I didn't really want to include it because I don't know if it's, worth mentioning, but here you go. And that's a great way for us to be able to communicate directly with you. I love getting to talk to, my dentist and help them. It allows me to help you more directly with the issues that you're having. And all this to say, kind of one final note before we dive into the DTX software, radiologists are writing a report for many different eyes. So we're writing it for you, the dentist. There's also other, specialists who can see that if you end up passing that report on. We don't know if you did the work or if another specialist did the work. And a lot of times the patient ends up seeing the report too. So there's certain things that we have to kind of dance our verbiage around. And if you're ever a little confused on what those things mean, go ahead and just message us and say, hey, did you mean this by this? Or can you give me a little bit more clarity than that? And we're always happy to do just that because we're here to serve you guys. So let's see it in action. Does anybody have any questions at this point? It's a great stopping point before we dive into the DTX software. I'm going to stop sharing my screen for a second while I pull that up. But if anybody has any questions, go ahead and share now.
So we had one that actually is going to bridge right into the DTX software about identifying the IAC, which I love that they're calling it the canal. They paid attention to the radiologist verbiage, but they're asking for what system and which view do you like to start with? And then do you double check from another area?
Awesome. I love it. And that's just about the IAC.
Correct.
Okay. Fantastic question. We'll definitely go into that. All right. Are you seeing my screen?
We can see it.
You can? Okay, good. Thank you. All right. So we have a patient loaded up, and this is on our DTX software. So obviously we don't have enough time to go through every single finding for a scan like we talked about. That would take a really long time, but we're just going to review some of the stuff that we haven't hit in terms of basic things for how you would want to review a scan. So we're going to go into this one and make sure that we have it oriented. We talked about that last time. Super quick refresher. We have our coronal, sagittal, axial, and volume rendering. Like I said last time, this isn't the software that I always use, so I'm a little clunky with it, so bear with me. So we talked about previously, the way that we can adjust our brightness and contrast is to go here, and then we can drag. So changing our brightness by going up and down, our contrast by going left to right. And I want to encourage everyone to let it be a little less contrasty than you would probably like to see. Martina, do you remember exactly where that special tip was to do the rotation?
Yeah, it was under the 3D X-ray tab. And then
there.
Oop.
Here we go. Patient orientation.
Yep.
All right. That was a good refresher for everybody. Let's go back so everybody knows how to find that. Because sometimes it's confusing to learn a new software. So I was previously in the 3D patient. This is where it kind of pops into first when you open a new patient. So I tried to pick one that was a super full field of view. So we're seeing, you know, a lot of the head and neck region. And then we're going to come over to 3D panoramic. And we're going to click patient orientation. And we remember from last time, we hit our little rotate button, and then we can, out here, use it to rotate in all planes. I think there's a little lag because I'm on. All right. That's looking better to me. We're going to hit done. All right. And now I'm going to start by showing everybody. So we talked previously about the focal trough. So that is, you know, creating the custom trough that is used to create our panoramic reconstruction. I'm going to kind of briefly show everybody to go through and make sure how we like that compared to, or just to make sure that we like that compared to the one that AI did for us. So we're starting in our 3D panoramic right here. And we're going to go up and hit panoramic curve. So we're in our axial view, and then you can toggle between the lower and upper arches. So we're going to do this for both the lower and upper arch, but I'm going to scroll to kind of the CEJ level of the lower arch. And I'm going to come up here. This is the one that the AI did for us. And this one actually looks pretty good, but I'm just going to show you all how to redo it just in case you want to learn that skill on your own. I think it's a good skill to have. So we're going to hit re-indicate curve, and we're just going to follow the directions that pop up down here telling us where to click. So indicate the region of the right third molar. It's okay if there isn't a third molar. We're just going to click the approximate region. Then we're going to go to the right canine out there. Then we're going to go to the left canine. And then we're going to the left third molar. And in the DTX software, they kind of automatically do these other points for you. So if you ever want to adjust those, it's a little bit confusing because if I hover here and you see the blue pop up, that's going to allow me to grab the whole trough and move it, which might not be necessarily what I want. But if I grab into one of these individual points and move it, then I'm able to kind of move it directly how I want it to. So I'm just moving it to include the maximum amount of the image. And I'm going to grab these and make sure that they're directly along my mandibular outline. That looks pretty good to me. I like that. So I'm going to hit done. That's going to lock that guy in. And then I'm going to do that one more time, but I'm going to do it with the upper arch. So I'm just going to scroll up here to the CEJ region of the upper arch. And I'm going to do the same thing. So I'm going to hit re-indicate curve, approximate region of the right third molar. And we can't see the region, but I know it's going to be right there in line with the other ones. Right canine, left third molar. There we go. And that looks pretty good. I actually like where it placed those. So I'm going to leave that as okay, and I'm going to hit done. And now we have both of those curves right where we want them to be. And now let's go into talking about the IAC. So I know we had a question about that, how we get this IAC drawn. So this is the one that the AI produced when it kind of took all the information about the scan in. But I'm going to say let's redraw these ourselves because I don't really trust it. I want to make sure that it is 100% accurate to the best of my abilities. So I'm going to go ahead and redraw those. So I'm going to go up to, let me remind myself where it's at. Here. Sorry, technical difficulties. Okay, here it is. So we're gonna go, we're starting at the 3D panoramic again, and we're gonna go, this is a little bit confusing, but see how there's this little caret beneath where we're at? So before we were here, we were at 3D X-ray. I know it's a really small little arrow, so it can be tough to see, but just know it's there. So that's showing us we're under 3D X-ray. I want you to go to diagnose. And if you want to have the software up and be doing this on one of the example scans, feel free. If you want to just hang with me and then, do it on your own later, practice on your own, that's totally cool too. So we're going to go to diagnose, and then we're going to go to nerve. Nerve. See that? And right now we're on our panoramic lower arch, which is great because that's where we want to be. I'm going to pop over here to layout, and I'm going to add in cross sections. Oh, I think it's because hold on, give me a second. Technical difficulties. I don't think it likes me being in the nerve. Here we go. All right, I X'd out of that. So now we're going to go to layout, and I'm going to add in a cross section. So these are the two views I like to have when I am tracing a nerve. And this is a really good reminder moment for how we're going to zoom in and move around our image. So to zoom in, I'm going to hit down Control. Oh, sorry, I'm going to hit down Shift and zoom in. I can zoom in, zoom out that way. So I'm going to start on the left side. And then to move the image over, you hit down Control, and then you can grab the image and move it over. So I'm going to leave it about there. I just want to see the left side of the image right now. And I'm also going to zoom in on these cross-sectional areas as well. And these cross-sectional areas are being created using that focal trough that I made. So I know I'm happy with that. And this bar right here is going to show us where we're at in those images. So each one of these lines is showing us where we are kind of going through those. So I like to start at the mental foramen. You can start either at the mental foramen or back where it exits posteriorly, but I would just start on one side or the other. And I am going to go over here, small, and then I'm going to go to nerve. And I'm going to go ahead and delete the current versions of the nerve. So I'm just going to toggle those off so we can't see them. Then I'm going to hit nerve. So I'm going to start, I like to start in the cross-sectional views and then, kind of check it with how it's looking and the reconstructed panoramic. And I believe that we should be able to change. I'm actually going to go back one more time. Sorry, this is a little bit clunky, but I'm going to change. Oops. All right, well, that was a good example of if you ever do anything you don't like, you just come up here to the top and we hit undo. You can always undo it. So I'm going to undo both of those because I didn't mean to. But I'm going to come up here to pan curve and I'm going to reslice the thickness. I'm going to go to single because that's going to allow us to kind of scroll through the panoramic like that. And so that's going to be my kind of method of checking, but I'm going to use the cross sectionals as to actually where to place my nerve. So I'm going to go to where the nerve exits the mental foramen, which I'm seeing right here. So I'm going to place my first dot right there. And then I'm going to start to scroll posteriorly. And this is actually a good example because I feel like this is a really, really, really hard one to see. So that's good. Let's see. So I can see it's right here. And I'm not quite seeing it for a little bit. And when I don't, I can see it pops down here. But when this happens and I'm having a hard time, sometimes I like to actually try and go and start at the posterior aspect instead. So let's do that. Let's hit undo, and then I'm going to come back here. And I can see where it's exiting the mandibular. So let's start there. See it coming down here. And I'm just going to follow it. Sometimes it's easier to see in the other direction. And sometimes you can't see it for a minute, but then I see it again. Oh, it's right there. I don't like that one. All right. And then when I think I've done it, I'm just going to right click to lock that in. And then I'm going to come back here and I'm going to hit reslice the thickness again, and I'm going to hit medium. And I'm going to make sure that that's where that is, approximately where that is. So let's go back. Let's make sure. I'm liking it. This little curve here is a little bit irregular, but I do see the canal right there. So I think it's real. So I'm going to leave it right there. If you're between a little bit of discrepancy and you're not sure if you're a little too high or a little too low, I always like to err on the side of too high. I would much rather be, a little too high with my nerve than a little too low and, get into a dangerous spot. And this is a good example of one that is a tough one because this is a younger patient and her bone quality is just not very dense. The canal is not very distinct compared to the surrounding trabecular bones. So this is a really good example of one that you would probably want to trace yourself or have a radiologist trace to the best of their abilities because the IA or the AI might not be, catching it 100%. So let's go over and let's do it with the right side as well. So I'm going to control and shift and zoom over to my right side. See if this one's the same or a little bit easier. Forgot to grab my bars before. Let's do that. And let's start at the back here. Yes.
It sounds like people in this group place implants. And so another thing to note is when you are struggling to draw a nerve, mentally make a note that the trabeculation is probably sparse. And so primary stability may not be ideal as well.
Yes.
So sometimes it's just scan quality, but I always, when I'm struggling to find a nerve, I always make a note in my reports to say, also the trabeculation is sparse. Keep that in mind as you're placing implants because it's not just that it makes this test difficult, it can also make integration a little bit less favorable.
Yes, that is such a great point about, this scan quality actually looks pretty darn good. So it's probably not the scan quality. It's probably that that is representative of the patient's quality of trabeculation. For this patient, it makes sense because they're a little bit younger. But yeah, if you are placing an implant, that's something that you're going to want to know because it's real, it's there, and it's going to affect your prognosis. So I always like to make a note of that as well in my reports if the IA is difficult to trace, even to just note that there might be a tiny bit of variability. There's also a couple rare times where you're just not able to definitively trace it. I would say that's on the much rarer side, but it does happen. So it's just that it's good for you guys to know that sometimes it's not you, it's it's the patient, it's the way that their anatomy is. So let's go ahead and trace this on the right side. If anybody has any questions too, as I'm doing this, feel free to pop it into the chat so we can know what we're doing next.
Just for the rest of the group, somebody had asked about when you're orienting, do you put the occlusal plane flat to the AP in the AP direction? And I
Great
put a
question.
comment in there about the Frankfurt plane and gave them a picture for that, as well as the hard pellet if it's a smaller field of view.
Yep. That's exactly what I do too. Frankfurt plane is the more ideal. Like that's what we would do if we had a large field of view, but if you have a smaller field of view, hard palette is a good rule of thumb. Funnily enough, I think this is being a little bit clearer on the right side for whatever reason. We just have our cortices a little bit more distinct. I actually think I was off a little bit there, so I'm gonna hit undo. Let's double check that. If you see a little jump like that, that's probably a sign to go back and check and make sure that you're right on. Because our canals don't usually move like that. So I like to
In
make sure that
terms
it's
of which view you like, do you typically do the pano reconstruction, or do you typically rely on the cross section, or 50-50?
I do 50-50. So I like to select in the cross section because I think typically, of course, I picked today the one of the harder cases to do, but usually in the cross section, you're gonna get more of a nice bullseye as to where the canal is, and it just really fits with your dropping, these circular points. You can drop it right into that bullseye. But the pan reconstruction can also be great to scroll through and just make sure that you're on. Like I can actually see here, I can see the cortices a little bit more clear than in the cross-sectional view for this one. So I always, some people like to drop them in the pan reconstruction. That's not bad. It's just, I think it's important to kind of toggle back and just check one with the other.
Completely agree. If I open up the pano and I see it really nicely delineated, I'm like, great, let's just do it from there. But probably 8 out of 10 times we end up needing to do the cross-sectional slices. One of the things as a new nerve tracer, I like to tell people is don't get hung up if you can't see it in one of the slices. You'll notice that Samantha, if she can't see it, she's like, no big deal. I'm just going to roll to the next one and see if I can see it there, because it's drawing a line. And so you don't have to connect in every single slice. You just have to generally get the area, every 5 millimeters or so.
And if you can't see it, it's usually just because trabeculation is really like the internal density of bone is a really similar density to the cortex of the mandibular canal. So if you're seeing any part of the canal that's not, totally a circle, it can look just like the nearby trabeculation, and it's a little confusing. So just like the Martina said, if there's one area where you feel like you can't see it, don't sweat it. It's more about the pattern of continuity and then making sure that the canal is making a continuous shape. It's not going crazy doing something that it wouldn't be doing. Does that make sense? So I felt like this one was a pretty tough one, but I feel pretty confident about the result that we got. So I'm actually glad we got to do kind of a tougher one together. Does anybody have any other questions about drawing the mandibular canal? No? All right.
Doesn't look like it. Yep.
All
You
right.
did
I'm
such a
gonna.
good job struggling for us.
Well, I'm glad.
That was a tough one.
I'd rather me struggle than you guys struggle. So
No, it was a good
let's
example. Absolutely.
let's pop back to our presentation. Oh no, we don't want to start from the beginning. Let's pop back to about here. And okay, further education. So I know I touched on a bunch of different things today, and I know we didn't even really get to go into the details in a lot of the anatomy. Textbook wise, there's two textbooks that I really like when it comes to radiology, like the two main ones I rely on. There are more, but the White and Farrow textbook, which is now Sanjay and Malya, and then the Koenig textbook are kind of the two heavy hitters that if you are like, yeah, I want to dive into this stuff, I want to learn a lot more, those are the ones that I would recommend. There's also hands-on courses in terms of the anatomy review. There is online courses. Beam Readers has several online courses. So if you're like, yes, I subscribe, I want to do as much as I can, you can go and check those out. And then, like I said before, Google and YouTube are really invaluable when it comes to the anatomic review of stuff. Acknowledgements. We got Dr. Martina Perrone, Jeff Brockett, David Hatcher, and the Beam Readers staff. And that is it for the kind of formal section. So I know it took a little bit longer than normal. This is one of my favorite little, decals about our radiologist day, but it really is fun if you get into this stuff. So a couple reminders, if anybody has any questions after we're done, feel free to email me. There's my email. If you are interested in sending scans to Beam Readers and you haven't before, you can go ahead and use the code Samantha50. That would set me up as your primary radiologist, which would be awesome. I would love to work with you. And it would give you 50% off the first scan that you submit. So just a little something, a little incentive to check it out. And like I said, if you're new to CBCT, go ahead and just try it and see if you like working with the radiologist, see if it adds any value for you. That's what we're here to do. And then one other note is we are going to put a link to the survey. We really want to know how this course was for you guys. Was it helpful? Is there anything that would have been more helpful? We're going to put a link to the survey from all 3 sessions in the chat. So if you, haven't done that for any of the sessions that you were able to attend or watch the video back of, go ahead and fill those out. So yeah, another question popped into my mind that somebody asked earlier, and it was how I generally review scans. I'm going to give the really quick overview just so I don't, miss that question. Obviously, it's a long-winded answer to say every single piece of anatomy as you scroll through. But for me personally, I like to start with the axial view. I know that that's the one. Let me pull back up our DTX so that we're looking at it. As we're doing it, let's go back to our 3D patient. I'm going to maximize it. So I like to start with our axial view. I know that this view is the one that is the most scary for dentists when we're starting, because it doesn't look like anything that we've seen before. It doesn't look like our panoramics. It's my personal favorite view. Now that I know all of my multiplanar anatomy and cross-sectional anatomy, because it just shows us really nice boundaries of a lot of the different areas that we're looking at and things. So I prefer to start there. I recommend that you always go from one part of the scan to another part of the scan. So it doesn't matter which way you go, but for me, I go superior to inferior all the way through the axial view, looking at some stuff, and then I go all the way back up through the axial view, looking at other things on my list. And then I personally move to the coronal view, and I start at the front. So I go from the anterior portion of the scan all the way through to the posterior portion. And I know it's really easy. This is a note. I know it's really easy when you get, back here to just breeze by it and not to go all the way through. I really recommend that you go through every single portion of the scan, because there will sometimes be entities within the skull base, lesions within the skull base that you are liable for if you took the scan. So you want to make sure that you're covering every single slice of the scan And then I come all the way back forward looking at the other structures that I didn't look at the first time. And then I do the same thing with the sagittal view. That's, oops, didn't mean to do that. That's the last one that I look at. So I'm going to grab and start all the way over on the right portion of the scan. And I always go right to left and scroll through and then scroll back through left to right, just looking at the structures on my list. If anybody has any questions about that, I am happy to go further into detail.
Yeah, axial is definitely the radiologist's favorite view. I think, hands down. I think there's a single radiologist that says, oh yeah, it's sagittal. But
yeah,
for none of us was that starting out, like Samantha said, our favorite view, right? It's the thing as dentists we've never seen before, and so it is scary. And I strongly encourage you, if you want to be doing your own reads, to just force yourself to be terrified, because you will be able to catch more things that way and take better care of your patients. So absolutely.
I'm going to drop into the chat the name of the resource that I really like to use for anatomy. This is what we used in residency. And it is like, if you want to get used to looking at the axial view, this is such a great resource. We got it for free in residency and I pay for it now because it's still such a great resource for me. So I'm going to drop that in the chat now.
Perfect. And then as you were talking, Samantha, you were mentioning our online courses. If there's a course you would like us to do that is not there, please just drop us a line and say, hey, I'd be interested in this topic. We are looking to build that library very actively in 2026. So happy to take input on that. And then I do have a question. I love that there's quite a few names that we've seen coming to multiple sessions. We're at the third and final one. Is this group interested in continuing this? Do you feel like this is a good enough jumping spot that you don't want to continue? If we did continue, I envision it more. So, Samantha's done an amazing job of leading this little group, but I would imagine it going forward being more led by the members of the group. So bring your cases, bring your questions, bring your workflow struggles, bring your, did I take a CBCT when I should have, or did I not take one when I should have? All of those questions. And, really let you guys talk amongst each other, as well as have an OMR facilitate that and provide guidance when needed. So I'm curious if you can give me a thumbs up if anybody would be interested, or drop a chat. I've also asked that question in the survey, so if you are completing the evaluation, you can just answer it there too. But it would be appreciated. Thank you so much, Samantha. You've done an amazing job really setting the foundation for this group.
Absolutely. It was fun. And, you guys, as for continuing something like this, a study club, that is the majority of what we learn in residency. Besides, going through anatomy and stuff, it's just getting cases and then it's talking about them and talking about them and talking about them. And we probably talk about them a lot more than the average dentist has time to talk about them. But if you guys are getting into CBCT and you want, somebody to bounce answers off of or ideas off of, I think it's a great place to start. Awesome. Thanks for that, Andrew. That's a great response to hear. All right. Well, with that, I guess we'll conclude. Please fill out the surveys. If you haven't, that is super helpful for us moving forward to figure out how we can continue to better serve you guys. All right, everyone, have a great week, great weekend, and really happy holidays. All right.
Thanks so much, Samantha.
Thanks, Martina. Bye, everyone.